It is my great pleasure to welcome you to our third and final day of the 2025 CareOregon Pregnancy and Substance Use Disorder Learning Series. Today's sessions are all around navigating the SUD continuum of care and facilitating coordination throughout. This morning, we will hear from two stellar panels. One is comprised of multidisciplinary staff from the 4 current Project Nurture sites in the metro region, and they are going to provide a grand overview of what Project Nurture is, how it saves lives and improves birth outcomes, how to connect folks to the program. And our second panel is an extra wonderful panel of peers with lived experience who will share their stories and highlight how their work improves the experiences and outcomes of those that they serve. Lunch is going to be served here in the ballroom, and afterwards we will have the opportunity to choose our own adventures. Dr. Amanda Risser will be discussing best practices for co-occurring behavioral health and substance use disorder during pregnancy. To the room just beside us in Morrison will be Dr. Wendy Smith reviewing withdrawal management and MOUD induction during pregnancy. We highly encourage clinical staff and prescribers to attend this session. Upstairs in the Portlandia room, Diana Smith will be dispelling myths and giving you tools and best practices for facilitating conversations around pregnancy and substance use. Each day has 4 sessions, and one can earn 4 CEUs for each day attended. Maintenance of certification Part 2 credits are available for our physicians to claim, and this can be done through the same evaluation link that will get sent out at the end of the day. The link for the evaluation can also be found on your printed agendas and on the very last slide of the day. Your CME certificates will come from OHSU, and they will be sent out at the conclusion of the learning series, probably later this month or early May. Please complete the evaluation within the next week so I can get those certificates processing for you as soon as possible. I'm excited to announce that days 1 and day 2 were both a success thanks to those of you who came out and made it possible. We had 180 people join us from 53 unique organizations. We've had a plethora of roles and disciplines attend. Look at you, creating community. Now I'd like to formally open day 3 of the Pregnancy and SUD Learning Series. And without further ado, I'd like to bring up our Project Nurture panelists. Panelists, welcome.
Hi, everybody. Thank you for joining us today. I'm Heather. I am the Kaiser MHAO Peer Support Specialist Doula that is here representing Kaiser. Our team consists of myself, another peer support. We have an OB provider, and then we have 4 family physicians that work at our Rockwood clinic. And then we have Annie, who is our co-occurring therapist. We have Sarah, who is our nurse. And we have Interstate and Rockwood, and then most of our deliveries are done at Sunnyside. What else should I say? I don't know.
Hi, I'm Julie Bennette, and I am a peer support specialist and specialty doula at the Legacy Project Nurture. We're centered out of the midwifery clinic at Legacy Emmanuel. We have 3 Project Nurture midwives, and we have 3 Project Nurture peer doulas, and we have just hired a new one who's starting on the 14th of this month. And we have a CADC who facilitates our treatment group, our level 1 treatment group. And our whole midwifery clinic is available to our patients that are in Project Nurture, and we are integrating into the hospital slowly. Lots going on at Legacy when it comes to Project Nurture, so I couldn't encompass everything that's going on, but Project Nurture is integrating into Legacy as we speak.
Hello, thanks for all being here. It's an honor to be here talking to you guys. My name is Josh Reagan. I'm a family physician and the medical lead for the Providence Project Nurture program. We have 2 different sites, both centered out of family medicine clinics. The main one in Milwaukee is actually in a residency clinic, so we're also working with residents and helping teach them about substance use. But we also have similar components. So we have a single peer mentor, we have a drug and alcohol counselor, a social worker extraordinaire, and a nurse who's sort of integrally involved. And then a large part of this for our clinic is also having like the other people who are part of our normal family medicine clinic being aware of who our Project Nurture patients are, and sort of when they call in or reach out, helping them kind of contact all of us. We also do, so there's mostly 4 main family physicians who sort of work the Project Nurture clinic, which is a half day every Monday, and then we have a periodic half day, usually for families with older children on Wednesdays. I think that covers it mostly.
Hi, I'm Hannah Kamsky. I use she, her pronouns, and I am the pregnancy nurse for the OHSU Richmond Clinic, and I help coordinate care for 2 different Project Nurture sites. We have our original partnership with CODA and OHSU, and then we've also expanded to a Richmond Project Nurture. I'm joined by my team here today, Amber, our fit caseworker, Erica, our peer recovery mentor, and Amy, our pregnancy nurse on the CODA side. And so we serve patients on-site at CODA, an opioid treatment program where folks are going to get their medication either in the form of methadone or buprenorphine, and we bring OHSU care on-site on Fridays. We have groups led by our doula, Christy, and then we serve both birthing folks and babies up to 1 year postpartum for prenatal, postpartum, and primary care. And then our Richmond site, we have a doula, Christy, who also leads groups for our Richmond cohort. One of the big differences is that at Richmond we serve patients up to 5 years postpartum, and patients can be seen who have a history of any type of use disorder, regardless of if or where they're engaged in treatment. That's a little bit different from CODA, whereas at CODA, folks have to be CODA patients, meaning they have an opiate use disorder and are receiving medication for their use disorder. And then we have 4 physicians who rotate through providing care to our patients and do deliveries up at OHSU, up on the Hill. We also have residents who rotate through and engage in patient care and extend their learning through providing care.
Say thank you, welcome. See, our first question is, how does Project Nurture address the unique needs of individuals facing substance use disorders and pregnancy simultaneously?
I mean, the first thing I'll say is I think having everything co-located in one location is incredibly important, and I think in our healthcare system that's so fragmented, we underestimate how hard it is for people to go to treatment centers and then to OB provider appointments and then different places to get social support services and meetings in different locations. And then I think another thing is the stigma that's been mentioned earlier, I think is really difficult. So having a place where our people can come and not feel like they're being judged and find other people and that's in their same situation, I think is key. I think those are probably some of the, I guess one other piece I'll just say about that is having drop-in hours is incredible. So having an open, our clinic basically runs from pretty much 1:30 to 5, and anybody who comes in during that time is pretty much going to get seen unless we're really crazy. And then if they want to wait long enough, we'll still see them. And so that makes a really big difference because I think I think it's all hard for any of us to make it to normal provider appointments, right? Like you have to get there early, and if you don't get there early, you are not going to get seen. And I think it's so hard for our patients to get there on time. And so if they're going to a normal clinic, most of them would not end up getting seen when they finally show up to that visit.
And I think that having your medical care and your recovery and it all in the same place with caring, loving people that are non-punitive, after being very scared, going to a place that is with no stigma, no judgment, treating you with respect and dignity, and helping you figure your stuff out, and providing resources and telling you that you can parent your child and helping you figure that out and telling you that you are worthy of doing that, all in one package, is kind of helps create an environment where the facility is given back we're giving their power back to them, and they can be part of that team as well. And so it's a co-creatorship with all of us once they enter into our services. And when they feel safe, that's when they are able to learn more and feel like they can do the things that they need to do for their lives. So having all of these services wrapped up and already available in a package for them when they get there is something that can give them their power back and their dignity back.
And I think with that too, for us being doulas, we get to meet them in the beginning and then follow them through their journey after their journey, and giving them that power to show them that they can do that. Sometimes we have to lead the way a little bit, but most of the times we get to walk side by side with them and sit in those very vulnerable moments of feeling like they don't have anyone to lean on, and we get to be that support for them today. And then having like a full team wrapped around you is, I know when I went through it, I was very alone and didn't feel like I had anybody. So being able to create that safe space for them and their families and show them that they can do this is really an amazing thing to do.
I agree with everything everyone said. You kind of took the words out of my mouth. But I think having a care team that's familiar with use disorders and treating them as the chronic illness that they are is huge, because that has not always been the case in the medical community. Knowing what the spectrum of care opportunities looks like in the community is also helpful, whether it be residential treatment, outpatient, as well as medications for use disorders, and being able to provide patients with options so that they have autonomy to choose what care looks like for them.
The only other thing I was going to add is I think the way there's sort of different comments about communication here, and a lot of it is around creating a place where people will be loved and respected. But a simple bare bones thing is that a whole lot of people who are in this sort of substance use community don't answer phones. And so if your model is to call people and communicate that way, it's not going to work well. And so I think having a team where people can use text is incredibly helpful.
What would someone's journey look like going through Project Nurture at your site? Could you walk us through a case example?
I've been doing this for quite a while, and I have so many different examples of people who have gone through this, and we meet people where they're at, so it is so vast. Meeting people where they're at, it can look so different. But what stands out to me is somebody comes in frightened, and when they come in, they realize that they do have an opportunity to be a parent, and they have an opportunity to not have to have a master plan of fighting an oppressive system alone. They have people that will help them walk through and navigate how to and be empowered to walk through a system that would usually want to take their children away. So there's some facility that's given back to them, some agency that's given back to them, some resource. And what's so beautiful to me is to see once we do help them with that, once they start doing that themselves. And so I sometimes say I have a couple PhDs in the streets, but I'm able to connect with people in a way that makes them feel safe and like normal human beings. And even though other people aren't seeing them that way, we are able to make a real master plan and figure things out in a way that are acceptable to society, and they get to keep their kids, and then they get to find their path to recovery. And then we execute that plan together. Well, there's a lot more to it than that, but I learn their story and I help them feel validated in their story. And I can't just choose one. This is happening all the time. And I mean, the end goal is them doing it themselves, of course, and finding their own team in the recovery community or in the world somehow, but it's happening all the time. It works. There's a formula to it. It works. We just have to show people that they matter and that they can do it. I don't know. I don't know really what to say.
So I think for us, and I know that you guys too, we don't have like you have to do these steps to get into our program. The only requirement is that you have a substance use disorder, and it doesn't have to be, it can be in the moment, it could be you could have 5 years sober and still want support during this time of pregnancy. So we do meet people where they're at. They can come to our clinic. A lot of referrals come from, within the Kaiser system through social work, hospital, providers. They send in the referrals and then they get put on our schedules, and then depending on what their journey looks like, if they want to get set up with any type of medication, if they're not ready to get sober yet, getting all those options that they have. Sometimes they don't get it until they deliver a baby, and then it's go time and a little panic sets in, and then we get to help them get to detox in the hospital or whatever that may look like, into treatment. And then sometimes they just aren't ready to parent, and that's okay too. So just meeting them where they're at in their journey, we get to support them in that. And sometimes babies go to family or foster care, and a year later they're ready to step back into that role of being a parent, and we help facilitate that as well. So it's just meeting them really where they're at and just helping them through their journeys and giving them all the options that they have, and just sitting with them in their decisions and knowing that it's okay, whatever they're feeling and whatever choice they make, it's their life and they get to do it how they want to.
So I don't think there's one way that care looks. I think of a couple of different factors. Care can look a lot different depending on when folks come to us in their pregnancy. Someone might come to us at 4 weeks in pregnancy. Someone might come to us at 38 weeks. And regardless of where they are, we're going to assess for what their needs are and provide the care that's needed. And then also, folks might come to us, the pregnancy might have been a motivator to engage in treatment, and so we're working on getting them on medication if that's what they desire, and working on stabilizing and recovery. Other folks may have been stable in the recovery for a decade and become pregnant and want care with us. So it can look a lot of different ways. And then through groups, folks are forming a community with others with shared life experience and seeing examples of really positive parenting of others in groups. They're getting to engage with our doula and get to know her before delivery so that they have that relationship and feel comfortable together. And then, yeah, as everyone said, it's just meeting people where they are, providing the care that they need when they need it.
I agree with everything everybody has said. I will just add that I suspect it's a little different when people show up in the hospital in each system. At Portland, if someone comes to the hospital and they're at least 20 weeks pregnant, so that means they're going up to labor and delivery. If they show up in the emergency department, they will almost always call our team to sort of help assess and come up with sort of follow-up plans. And so if you guys are out there and you're trying to figure out how to get help for somebody in our system, you can always reach out to phone numbers if someone's pregnant and doesn't want to come to the hospital. But if you're really desperate and someone will go to the hospital, it's a place that a whole lot of people get connected. And that, again, includes whether or not they've just had their baby or whether they are still pregnant.
What do patients find most valuable about Project Nurture?
I think, well, what they say to me is that they feel seen and heard and respected, and that everything that they were hoping for as far as parenting their children or not, they were able to follow a path that they were able to design and were supported through. Their fears were heard and supported. They didn't have to do it alone. We're not supposed to do it alone. So that's the most prevailing thing that I've heard from people from Project Nurture. Yeah.
Yeah, I think just the value is giving them that safe space to just be with whatever their situation is and with no judgment. People that actually care about what they're going through and either have been through it or know how to support them to get where they're wanting to go. I think one of the biggest things that I get from my peers is, I wish I would have come to you sooner. I wish I would have trusted you sooner. And I always tell them it's okay. Like, that's why we keep showing up for you when, you don't think that you can do it, because it is a hard journey to take that first step to get to where you think or you want to be. So just giving them that consistent space to be who they are and just feel their feelings.
I've also heard from participants that the community that they get to be a part of through groups is really valuable. We've had a number of folks who participated in Project Nurture and then became peer recovery mentors and then have brought folks they're working with in the community to groups. So seeing that kind of full circle community has been really amazing.
And I'll just say that I like to think at least that they feel a little bit loved by us, and that they feel that there's a place they can go where there's stability. I think a whole lot of people in this situation have almost no stability. And then also that they're trusted. I think this is a group of people who feel like they've been told that they shouldn't be trusted, and I think to give them some of that trust back is really important.
Are medications for use disorders welcomed and incorporated into treatment? And if so, how?
Yes, absolutely. Well, for our site, we are co-located at an opioid treatment program. So folks there are getting medication either in the form of methadone or buprenorphine. At our Richmond site, we have a whole medication-assisted treatment team, which provides various medications for opiate use disorder, including buprenorphine, both sublingual and injectable. And then we do also do some treatment for alcohol use disorder, though I don't see that as commonly.
I would echo those same comments. We do both outpatient and inpatient inductions for buprenorphine, so we will usually try to kind of taper people onto buprenorphine a little bit over time if they want to do this as an outpatient. Inpatient, some people, and we kind of find that some people will do it some places great, and some people just refuse to do it those places, and kind of, again, meeting them where they're at and trying to find a place that works for them. We will do buprenorphine inductions in the hospital. And then the other thing that we run into a lot is methadone. I think is just really hard for people to get onto. I think it often takes people over a month to get to a stable dose, and if you're going every place every day for a month, you get tired of it over a period of time and maybe lose some hope. And so we can bring people into the hospital and get them up to sort of a reasonable dose of methadone within a few days, actually, and that can, I think, stabilize people even if they're returning to the outpatient setting. So we do all of that. And we probably try to convince most people that it's a good idea, but obviously we don't force people. It's what they want to do.
So methadone and buprenorphine are essential tools to recovery for some people. In part of meeting people where they're at, we provide that option. And access to methadone can be something that we do have to work a little bit harder for people. And I feel like sometimes peers in general have to be a little bit of a social justice activists in a way, and we have to go out and make accessibility a little bit better for our clients. And we find resources and ways. We make paths where there aren't paths sometimes, or find where they are if people don't know where they're at. But we meet people where they're at. If they want it, then we help them find it, and we help them create a life for themselves that is better than the one that they had before. And so if that's it, then that's what we help them fight for. But if it is a part of, if it's going to be what they want and it's part of their recovery, then we make a way.
Yeah, we have on Tuesdays in our clinic, at either site, we can do the BUP induction, and then we also offer Sublocade at our interstate location. And then our hospital setting, sometimes we are able to do inductions on the Suboxone or methadone, and then we have to find an outside provider for the methadone clinics. But all of our providers can prescribe medication for our patients.
What strategies do you use to build trust and rapport with clients and patients, especially those who have experienced trauma?
I think, again, consistency, showing up for them when they feel like they probably don't deserve to have a shot or have been told no so many times, or you're a disappointment so many times, you don't deserve this. I think just being consistent, compassionate, and showing understanding to their situations has been a crucial part of it.
So yeah, consistency is very important. Sharing pieces of my story, and empowering the parts that are frightening to them, showing up and being a model and advocating, and finding out what their story is and their worldview, and learning with them and asking the questions that they're frightened to ask, and really walking through the process with them and showing them that they can live through some of the things that they're afraid of. As a doula, I create safe spaces and empowering spaces. So I really tune in to what they're going through, and if they're afraid, I can kind of feel it, and I get rid of the scary people if I have to. And I show them that they can too. And I show them how to advocate for themselves. And once they see that they can do it, and that they are gonna live through it, I refer back to those times as I'm walking through other things with them as their peer. I use their birth story as their power sometimes. Being their doula and their peer is very amazing, and I can use that ongoing in their life because they don't know how powerful they are either. So I kind of blend it together as their doula and their peer, because I see their power, and I always see them as whole. And so I kind of use art in that way for them.
I think of a few different things that I sort of try to focus on. One is I think in the medical field we lose sight of how scary it is, right? Like we work in it all the time, and they come in, and anybody coming in, I mean, whether or not you have a substance use disorder or not, I think labor and delivery is a terrifying experience for people. And we're like, it's normal, what are you worried about? And so I think sort of letting people know how brave they are is something that I continue to work on. And another piece of that is sort of reassuring them that they're doing a good job parenting, I think is really helpful. You find the things that they're doing well and you emphasize those, because this is a population that doesn't feel like they're told that they aren't not going to make good parents, but they also at some level are really worried about that themselves, I think. And then the other two things I think about, one is just transparency. As much as possible, like I try to predict every possible thing I can picture happening to them, and I tell them about it, because I think people having an idea about the different things that might happen feel less likely they're having the rug sort of pulled from under their feet when things actually do happen. So that's a key thing. And then I use normalization a bunch, and so I guess an example of that, things that happen in the hospital, for example, or substance use happens in the hospital, right? And people bring substances to the hospital. And I try to sort of partly transparency, but partly normalization. I tell people like, hey, it would be almost crazy to come into the hospital without substances, right? Because you're scared that we're not going to take good care of you and you're going to be absolutely miserable. And I think having that conversation with them, like that it's normal to bring substances into the hospital. I think another thing I've brought up recently is that it's normal for people to want to flee the hospital. Like it's a scary place for people. And so I'm trying to ask people like, wow, you've been here for 2 days. Are you doing okay? Like a whole lot of people in your situation would want to get out of here. And it's probably not surprising to you guys, but to medical providers, we're like, what? They want to leave the hospital? That's crazy. And so just kind of normalizing things and just going to places where they're probably thinking, so that they don't have to bring it up themselves or that they feel like they can talk about it, I think is really helpful.
As a nurse, I try to provide anticipatory guidance to patients around what to expect in different care settings, especially if it's something that might be a sensitive exam, like letting folks know dating ultrasounds typically happen with a transvaginal ultrasound probe, so that patients know to expect that when they come in and aren't surprised by that. I also try to provide choice as much as possible, talk through what various options are, and allow patients to have the autonomy to make the decision that feels right for them and their body, and then respect their decisions, even if it's not what I would choose for them as a medical professional. Respect that they have the autonomy to choose what happens for their care and their body.
In what ways do the disciplines in each site collaborate and communicate in order to provide holistic support for clients throughout the perinatal continuum? Or in what ways do each of the disciplines work together to get somebody from intake to the postpartum period? How do you guys work together?
I feel very fortunate to have the team that I have. We're very close-knit and very well communicate daily. We have twice-a-week huddles. We have Tuesday huddles, which is all like our Tuesday group of clinical staff, and then Thursdays our hospital staff. So we meet with the social workers and kind of give them updates on upcoming deliveries and how we can support them, or they reach out to us when there's a delivery of how we can come meet them where they're at. And then also with our lovely labor and delivery nurses too, I can go in and meet with them and ask if they need any assistance. So just having that open communication with everyone on the team is very key and crucial to keep us all flowing together on what need to be met at certain times throughout their journey.
So we have a weekly huddle, and we have text threads, and they know I'm ADHD, and so they make sure that I get all of the information as much as possible. We have haiku and epic, and we're just a family, and we communicate the way a semi-healthy family communicates.
I would echo all of that. You know, it's a fairly small group, I think, at each site, and our group is also fairly small, and we have a weekly huddle where we kind of review most of the patients and kind of what their needs are when they come in, and then lots of teams messaging and lots of messaging when somebody calls in and needs something urgently. Whichever person they reach will kind of reach out to other people and figure out kind of just how do we get those needs met at the time. I'd like to think we're a whole lot more accessible than your average medical clinic from that perspective.
So we huddle weekly with our whole interdisciplinary team and run our list of patients to talk about what needs each patient might have and who's going to be the point person for each of those needs. We have the unique challenge working across two organizations, CODA and OHSU, that we have different electronic medical records and we don't have access to each other's medical records because we are employed by each separate institution. So we live and breathe releases of information. And then outside of our weekly huddle, if we need to be in contact, we'll usually text each other like, hey, can you call me, because we don't want to send any PHI on text message. So we'll be in touch via phone as needed outside of those weekly huddles.
And I just want to add in that this is all sort of from a patient care perspective, but I think another key piece about this is that it's a high-risk population we're taking care of, and things don't always go well. Like, you see sometimes really bad things happen to people, and it's heartbreaking, and having a team of people that is close like a family is really helpful, I think, for the sustainability perspective, like being able to talk to each other and give each other hugs and cry together when things don't go the way you want them to, I think is really valuable.
I second that.
How does Project Nurture support parenting goals?
I kind of feel like everything we do is around parenting. So the first piece of that is like just the realization of helping people become parents, which I think is their number one fear as they're becoming pregnant and realizing that they're not able to stop using a substance. So it feels like almost everybody, I think that's the number one question anybody has when they see us. It's not about what do I do to make this pregnancy go well, it's how do I keep my baby and my, so that I'm their mother. And so everything we do is motivated around trying to help them meet that goal if that's what they want to do. From the perspective of, there are a couple little things that I'll point out that are just, I think, really valuable. One is things like charting, and what gets charted matters a little bit. And so like when DHS is reviewing whether somebody should, like when there's a court case, they're actually looking at what gets mentioned in charts. And sometimes things in charts are really mean, and maybe they're not written in a way that is meant to be mean, but things can be interpreted different ways. And so I think it's really important when we're charting about patients, whenever we're writing things down and we're sort of trying to support parenting, that we do it in a way that's kind of thoughtful and won't necessarily hurt them if those records become available. I think we think of records as confidential, and surprise, surprise, they're less confidential than we all think they are. And then we are working currently on creating sort of more of a parenting group. So we've been sort of struggling to try to figure out how to help with parenting. A whole lot of our parents feel like they didn't necessarily, some of them had great parenting, role models, but some of them had less so. And so trying to support them with those kind of questions and come up with groups where they can talk about things, stuff like that, we're still working on.
I'm really glad that you mentioned charting and what goes into our charts, because that follows people their whole life. And I have personal and I have peers who have experience with what goes in the chart haunting them later in life. And so I'm seconding that as well, what Josh said. And I have notes, and I just wanted to say that we believe recovery and parenting go hand in hand, and that we want to have people healing while they're parenting. And so learning how to recover, there's pieces of recovery that can go into like recovery, you ask for help. In parenting, you need help. There's different pieces that you can align to your recovery, that you can align to your parenting skills, your recovery skills and your parenting skills. We navigate DHS with them. We navigate the court systems with them. We follow them through the first year of their parenting. And actually, we've extended it to the first 3 years with a recovery management group, which recovery management is on the stages of change. So we have added a recovery management group. And it all is connected with parenting and recovery. And that's why we're here, so that people can parent their children.
Yeah, I think just because you have a substance use disorder doesn't make you a bad parent. You can still be an amazing parent. In our groups on Tuesdays and Fridays, it's our mommy support group, so all of our patients can come and kind of share together what they're struggling with, or if they need help with something, and get feedback from each other. They call me Grandma Heather at Project Nurture, so just getting to be kind of that, like Josh said, if they haven't had a positive role model as parents in their life, like we get to emulate and kind of help them through those situations. And it's really like, Grandma Heather's here.
In addition to what everyone has said, we also help get parents connected with tangible supports for parenting, like getting connected with WIC, to have supplemental healthy food or formula. At CODA, they have connection to the diaper bank, so getting diapers. Our nurse Amy also helps folks get connected with the Health Share Project Nurture new parent package that provides items to help support new parents.
And even having like a location where kids could come with their parents and have fun. So like we have toys and we have food and we have clothes for kids and things like that. So I think that makes a huge difference for people feeling comfortable at a place.
And one last thing I'll add in is that also having a fit caseworker to help families navigate the process if they have DHS child welfare involvement is huge. Amber can help walk people through what that might look like. She helps us as a team understand the different kind of stages or phases that a family could be in. I don't even remember all of the terminology. Amber's our expert, but child welfare is so complicated, so for families who have that involvement, it's a huge benefit to have Amber by their side. She can go to court with them, and it's also kind of this mysterious world to us as a care team, so she helps us understand where patients are in their process, what it looks like for them as a family, and how that might have impacts on the care that they might need.
And another thing that I want to add is that we provide a car seat and stroller, and we have a clothing closet, and we hook them up with mother and child, and we want to make sure that they have all of the supplies that they can get. We teach them, I said earlier, how to ask for help, and give them little tips and tricks, and connect them with different services. I just recently have started connecting people with postpartum doulas as much as possible, trying to get VOA actually is going to be starting a postpartum doula program so that they can have 24 hours of postpartum doula availability. I hope all the treatment programs do that. Oh my God, it's gonna be so amazing. Everybody needs a postpartum doula. Parents need help, and parenting is hard, especially when you're in early recovery. And these moms need to know that they're worthy of that. They need to know that they deserve help, and that their addiction is not a reason why they wouldn't get that.
Now, we'd like to open the next 30 minutes up to audience Q&A. If you would, please, if you have a question, please raise your hand very high, and Peter or someone else from CareOregon will run a microphone to you. Please join us in our efforts to be inclusive and to make this accessible for those who are hard of hearing. And we know that you can yell. We don't want you to, and you don't have to.
This will kind of be a leading question, but my question is how does Project Nurture collaborate with outside treatment providers outside of CODA, like even residential sites or things like that? And if you guys do, thank you.
I think us as peers, like we get to go out in the community and build those relationships with the outside partners to make that connection, that one-on-one connection, and being that point person to communicate with them through is really crucial in building that relationship with outside treatment centers.
Yeah, I try to make everybody my best friend because I want to have resources at the ready. I kind of treat it like how I would my own children. Just like Heather's the grandma, I am too, and the way I would expect to do it with my own children, my child care providers and my neighbors and everybody are my best friends, just to make sure that if my kids need them, they're there. And so I do that the same way with the community. I want to bring community together. We need a network, a net, and I want everybody to be available and together and working together because it takes a village. And so I be best friends with everybody that I can so that I can call them and have them on speed dial and say, hey, I got this person for you, and it's easier that way. So hi, everybody.
That's actually an incredibly important question, and I'm so glad you brought it up. I think, I can bring up examples of situations that work really well, but basically I think what works best for us is sort of inside contacts, right? So like Maria, our social worker, does a huge amount of contacting back and forth with treatment programs, and Letty Owens does a really good job with us by actually having a nurse who will send us messages when she's worried about one of the clients that they're taking care of. And then another example of what works well is that one of the, Allied at Belmont has a doctor working there who will communicate with us and make it easy to transfer patients back and forth. And having those sorts of connections are key, and we probably need 5 times as many as we have, and it doesn't work as well when we don't have good connections like that.
I agree. Connections are huge. We have many patients who go through treatment at CODA, GRC, and Letty Owings, so I've worked over the years to form relationships with them and have contacts who I know and trust and can call and collaborate with. If I'm working with a treatment center where I don't have a connection, I approach with collaboration and curiosity, like, I really want to figure out how I can get the patient what they need, who should I talk with, and kind of approaching through that lens. With that said, if there's anyone from VOA or Project Network here today, I'd love to meet you. We haven't had as many patients there over the years, but yeah, connection is key.
Hi, I have a question regarding how can non-peer doulas and childbirth educators be involved or get involved in Project Nurture? And are there lactation consultants and lactation counselors involved in Project Nurture?
I would like your number, and I will definitely call you if we need backup. Like I said earlier, we are going to be starting a postpartum doula program pilot project at VOA, but I would love to see that spread out to other treatment centers. I think on the ground, we need as much resources as possible. I think that once the news starts spreading that people are actually interested in helping instead of judging, that people will actually start getting the help. Right now, stigma prevails, but once people know that that's not the case, we'll see more people wanting to get help. It's a culture change that we need to make, and so we'll need all the hands, as many hands as possible once that's happening. So everybody give each other's numbers if you're wanting to help. Yeah, we need to make a network of support. So I will take people's numbers for now and start there, I guess.
I'll say that we look very professional and organized up here, but partly all of our programs have been just scrambling as hard as we can to do the basic care, and so we haven't had opportunities all the time to create that, but I think it would be fantastic. I will say that a lot of the sort of systems in place are hard because of that stigma again, so like we have mother-baby clinics where patients can go, and sometimes they have a really good experience and sometimes they have a negative experience. And they're like, I'm never going back to that lactation clinic. And we're like, your baby's lost like 1.5 kilograms and we need you to follow up. But if they have a bad experience, they're not going to go back. And so figuring this out would be really helpful. And I think it's going to take conversations. Oh, and we have, in our program, we have 2 of the family docs that work with us are certified sort of lactation specialists, so that helps also, although they're not always, yeah.
So as Josh mentioned, programmatically, there's always some barriers to things like financial sustainability and staffing. So we do have a phenomenal doula, Christy, who does take on backup doulas, so I'd say I can put you in contact with her. But in addition to getting connected with Project Nurture, there's such an opportunity in the community for doulas to enhance knowledge of substance use disorder, be an ally to the community through the individuals that you work with outside of Project Nurture as well. So I think that is something that every doula could do. And then we would love to have a lactation consultant. We typically send folks up to OHSU up on the hill, but it can be hard to go to appointments up on the hill. It's not the most convenient location. I wish I had a funding magic wand to hire a lactation consultant, but I don't have that, unfortunately.
We have just reached out to the doula hub at Legacy to see about harm reduction doulas, because we are starting to, I don't know if I'm even supposed to be talking about this yet, but to the MOUD admissions, expanding that, but being available as a harm reduction doula with expertise in other forms of support that way. And being trained to help with this population is going to be advantageous, and just making yourself available that way at the different hubs is, I think, going to be helpful. And me having your number so I can let you know more as it comes.
Good morning, everyone. My question is for the mothers who end up not having a productive pregnancy, does Project Nurture offer like grieving therapy and different things like that? Because we know that not everyone's going to be be able to have a happy ending. So I was just wondering, how does Project Nurture handle those?
So we have with our OB, Dr. Davidson, she also runs an OB or a abortion clinic too, whether it be medically done, like a necessity that needs to be done, or they choose to go that route. She does provide those services, and then we have an amazing abortion counselor that goes along that journey with them and her little team that she has too, and they're wonderful people. And if they need extra support from myself or my other peer, we will give that to them as well.
I do support in a full range of doula, so not full spectrum, but in bereavement support. But I also send people to Yassine's Love. They have a one time a month, I believe, support group for loss. I forget exactly what it's called, but Talia Anderson at her location has a support group that I send people to regularly that is amazing. And I have a flyer for it if you want me to send it to you. But I usually give people support group information and doula them as well.
Just to sort of emphasize another really good question, right? Because a lot of what we do is in this group setting, and in that group setting, there's babies and there's moms and it's a complicated place, I think, for people who have had like a stillbirth or also even if they've lost their child to the DHS system. It's a really good question. We basically talk to people and try to figure out what works for them. We could see people across the hallway for medical visits. We certainly could reach out to people and talk to them kind of not in the normal clinic setting, but a lot of it's kind of a conversation and trying to figure out what works best, and then all the other referral resources that everyone else has mentioned.
We offer integrated behavioral health, either in the form of office visits or virtual visits. That's available to all of our patients. They generally work with folks shorter term, and if someone's interested in longer term therapy or counseling, they work to get them connected with someone in the community.
Good morning. Hi, everybody. My name's Ashley. I'm a case manager that works with the navigation team, and we work out on the streets. And my question is, so we run into pregnant women often, and I have a really hard time finding them housing or housing resources unless they're like 100% sober. So do you guys help with like housing or housing resources for women?
Housing is a struggle here in Oregon, or Portland at least. We also have probably the same, you probably have more resources than we do, but we are connecting people with like Central City Concern, especially if they're not. Central City Concern has like the wet shelters, and if they're not wanting to get all the way clean. But we are connecting people quite frequently with different clean and sober places, and putting them on wait lists, and resource galore.
It's a mess, I get
It
it.
is a mess.
It's a mess out here. My second question is, do you help single fathers?
We are doing the best we can to help them. It is an important part of the family dynamic that we make sure that we are paying attention to and aware of. And we find resources for the fathers if they are willing and wanting us to. But we can always use more resources and bringing in the village for them as well.
Yeah, if there's a father that is wanting to parent their children or in any capacity, whether it's together or separately, if we can and they have that willingness, we will step into that space for them.
Hi there, my name's Helen. I'm an educator and training coordinator for Planned Parenthood. My question is, if you have someone who comes in asking to end a pregnancy or wants support ending a pregnancy, can they still access the same resources, peer mentorship, postpartum support?
Yeah, we have that same opportunity for them at our clinic.
They are totally welcome to stay if they so choose to. Oftentimes I find that they don't want to stay around people who are parenting. And so I often look for other resources for them. If they want to stay, they are more than welcome to be utilized. We kind of have a choose your own adventure with Project Nurture, and you can pick how you're going to utilize our program. And sometimes they'll just stay for midwifery care or women's health. Sometimes they'll utilize the peer. It depends on how they want to be in our program, but they are always welcome. Oftentimes I'm seeing that I'm finding other resources for them to continue on with support.
I think an overriding idea is that none of us want to leave people in the lurch, right? Like they come to us and they're in a tough space, and none of us are gonna, I don't think any of our programs would be like, oh, sorry, you had an abortion, we're not gonna take care of you anymore. And so it's all about just sort of finding exactly what people are saying, what their needs are. And you know, we have a family medicine clinic that we are also part of that's right across the hallway, and we will sometimes provide care in that setting for either dads or for people in that same situation, or if they want to kind of keep accessing more of the resources, just like Julie said, we will certainly welcome people in our program for pretty much as long as they need it. I mean, that's not usually 2 or 3 years out. By then, they're, you know, we wrap them back into our normal primary care clinic. But our primary care clinic is really focused on treating people with substance use disorder also. So in that setting, hopefully, people are feeling supported.
Yeah, we support all options in pregnancy, and folks can continue to engage in care with us as they choose.
Hi all, this is Amy with the Project Nurture CODA OHSU site. So I'm on the CODA end, and I just wanted to mention really quickly that if a patient were needing a little more help with grief counseling or single parent help, if a patient is at CODA or probably any other MOUD treatment outpatient location, they have available to them a counselor and counseling, and CODA does have grief and single parenting, well, any parenting groups, so that could be male or female. So they could reach out for a counselor that they already have available to them if they are getting methadone at a place. And then for my leading question for the group, we all know that patients around town have available to them these 4 large health providing agencies, but and they may get care here or there or everywhere in little bits and pieces over the course of their life. How does it work to coordinate care between your organizations?
We call each other. Yeah, we can call each other, and I have Heather on speed dial, and she calls me. Josh, I can call. I mean, you guys want to answer that?
Yeah, like we had a non-member show up twice at our labor and delivery, and you know, we asked if she wanted to switch over her insurance, and if she doesn't, then I can pass her off to one of these lovely people, and we're just on speed dial.
I don't think I have anything to add to that. We just reach out to each other and talk with each other.
Hello, thank y'all for being here today. I've really appreciated everything you've had to say. There's a few different ways I can ask this question, but I think I'm going to ask it in a magic wand way. I've heard each of you talk about areas of the programs that you're really fired up and excited about. If you woke up tomorrow and there was endless resource for one priority, what would each of you like to focus on?
Housing.
Okay, beside housing.
Besides
just coming from the medical side where we have people drop into the hospital and just not have support, we are way shy on residential treatment beds for moms and babies, and and that's a stressor on the hospital. It's a stressor for patients. It's like you have to line up a discharge date with a magical time that might be available, and sometimes if that's not available, then another spot's not available for another week, and that's just a mess. So housing first, and then probably I would put residential later, but if you can also wipe out stigma in there, that'd be great.
If I had a magic wand for this population, I would have a Project Nurture Village where they could all come, get all-encompassing treatment, detox, in-home care, have, supplies dropped off, whether it's diapers, wipes, food boxes. It's just, that's my fantasy dream.
Yeah. Besides housing, that means we already have housing then, right? Yeah, village, people, love, people working together, helping people out, not hurting each other, I guess. Because I also wanted to say, like, the stigma thing that I said that is prevailing. It's the internal stigma and the external stigma, and I wanted to make a very big point in making sure I said that.
I'm having trouble deciding between two ideas. One, a cozy place outside of a hospital-based setting where we could up-titrate people's methadone dose quickly. That or universal health care so that both would be great.
I think one other area that we run into trouble with probably is communication with DHS. I think DHS is a really big wild card in the picture, and having the whole process feel a little bit less insane would be nice. And sometimes it works really well, but you can never count on it working really well. And so I'm sure we could imagine some way to make that system work better.
Yeah. Good morning, my name's Tara and I work at Fuentes with Central City Concern. Thank you all for being here first. Second, I was wondering, do any of you identify as being a person in recovery? Excuse me, and do you have any culturally specific portion of your program?
I am in recovery. I started my recovery journey in 2005, but I'll have 12 years clean in June. And I also have a couple PhDs in the streets, so my lived experience is vast. And I am also culturally ambiguous, racially ambiguous. I say that I'm a they, them in the racial community. Nobody knows what I am. And the cultural, we do need to diversify our workforce, absolutely. And I do that as much as I can by building community, by bringing community together, by joining forces with other organizations as much as possible, by speaking the truth. It's quite a unique experience with nobody knowing what I am racially, because I get to see all the things and people don't get to know. People act any way they want to around me. Racially, I see all the things, and I bring people together. It's one of the unique aspects of being racially ambiguous and nobody knowing what I am. I get to say the things that some people don't get to say, and I get to see the things that people don't want me to see sometimes. And I bring people together. And that's why I know also why it's so important that we have to be a community, and why we have to come together, and why we have to have more village, and less stigma. So thank you for asking that question. We do need to diversify the workforce a lot more.
I have 6 years in recovery, so and I think it's just building those relationships with community partners for specifically if someone's coming in looking for a specific route to go, having those connections in the community, whether it's Native American, Hispanic, African American, having those connections in the community so we can help them get to that point.
I am not in recovery. I just really like people who use drugs, I think.
Good morning, Lachey Sanford from Imani from Central City Concerns. I was just wondering how many locations does Project Nurture have? Do you have just the one, or do you have more than just one?
I'm trying to count on my fingers right now. I mean, all of us represent different sites up here right now. So I'm OHSU in Coda, Providence, Legacy, Kaiser, and then we're also working on opening a site at East Portland on the Adventist campus, a partnership between OHSU, Family Medicine, and the Adventist Midwives.
And then many of our sites also have, so we have a site in Milwaukee, and we also have a site, which I neglected to say at the start, which I'm feeling really bad about, in North Portland. And I think that's true with Kaiser also.
Yeah, we have Interstate, Rockwood, and then our main delivery hospital, Sunnyside. I would like to branch out to the west side and up into Salmon Creek, but we do work all over the counties, so we cross over. We just don't have like in-house working relationships quite yet, so that's the next steps.
So it sounds like you guys are based in Portland, and I guess I have two questions. Is Project Nurture outside of Oregon? And if so, are there spaces in rural communities that you see Project Nurture working really well, or if there is opportunity for rural spaces, or what barriers you have identified in not happening in rural spaces if they're not there?
So we also have I guess you would say, yeah, we have CareOregon, so we work kind of side by side in that aspect for the rural communities. And I don't know that we, outside of Oregon, other than like we can take people all the way up from Longview down to Portland.
So I'm Mimi Chode. I'm a family physician in Medford, and I work at the Oasis Center. And we are one of the CareOregon sites, and we serve the entire state. And we have folks that come from Northern California, and it mostly just has to do with insurance agreements is the primary limitation. But yes, we actually have a very successful program that serves much of southwestern Oregon and Northern California. And kind of to answer the village question, our model is we have emergency housing on site for pregnant women who are seeking residential care. So there is sort of that was a model that we started several years ago and has expanded through several of our community mental health and treatment facilities now have other locations around the county. So we probably have more available resources. Our population is obviously smaller than the Portland metro area, so we maybe have a little bit better ratio, but still obviously lots of need. And what I wanted to also throw out there is that, as with all of these locations, we have integrated primary care, prenatal care, and treatment all in one location. For our particular site, we are a primary care site. And so for any client who is dealing with substance use disorder and is a parent of a young child or pregnant or with pregnancy, we can take care of them and their entire family. So if you run into anybody up here who is from Southern Oregon or is interested in coming down, we do have space for that, and we're always happy to take a phone call and help facilitate that. So yeah, let us know.
And there are other examples of Project Nurture type programs in other states, without a doubt. I know Seattle is a good example, and Washington has several. Swedish is sort of, I think, most famous for that. And there's a variety in other places too. Colorado, California, but there's also places that have, there's states, whole states that have nothing.
Hi, my name's Becca. I'm a behavioral healthcare coordinator at Women's Healthcare Associates. So we coordinate, we work out of Providence, we work out of Legacy. My question was, if we want to refer a patient to Project Nurture, my understanding is it's self-referral through CODA, but I wasn't sure if there's like a better referral source or, how to refer a patient to Project Nurture.
For us, often somebody from WHA or the Providence Women's Group will just reach out to Maria is probably our most common point person, I would say, but our peer mentor also will take those calls. And so all you need is a phone number, and you can either text or call. Or probably I know there's ways to do things intra-epic also, but in between systems. I just haven't ever figured out how to do that.
Isn't our contact information on a website?
I believe
Project Nurture, and then it has all the sites, contact person, and how to get a hold of them to do a referral.
Sometimes, every once in a while, I think providers want their patients to go to us, but the patients don't want to go to us, and so that's just something to be aware of. Like, a whole lot of providers feel like our patients are hot potatoes. It's funny because I really like them, but that can sometimes be, I think, challenging. And people get to know their provider, and even if they've seen them just 2 or 3 times, sometimes they just really like who their provider is, and they're scared to go somewhere else. So there's lots of good reasons that people don't come to us.
All right, let's all adjourn for about 20 minutes and regroup here at 10:45 for our next panel session. Thank you.